Lawrence H. Beck. Dr. Beck is a graduate of Harvard Medical School. He did his residency and fellowship at BMC, and he's currently the David Salant Professor of Nephrology at BMC. His clinical focus is glomerular disease with a research focus on membranous. And as you're probably all aware, he forged the path on the PLA2 receptor antibody as a biomarker. So Larry, I look forward to hearing your talk.
Thank you, Alice. And I was just informed this afternoon in clinic from one of my membranous nephropathy patients that tomorrow is Membranous Nephropathy Awareness Day on Facebook. So there's something happening at 7 on Facebook. I don't know how that happens, but just learned of it today. All right, let's see. So this is me. I have some disclosures. And basically, the purpose of this 30 minutes is to recognize clinical and histopathological features of membranous, and more importantly, I think, discuss the use of serology in diagnosis and monitoring of disease to judge when immunosuppression is indicated and when it's working. All right, so this was not the patient I saw today, but I do have several like this. So a 52-year-old man presents to his primary care doctor with several months of weight gain and worsening lower extremity edema. Blood pressure is slightly up. And the physical exam is only notable for basically 3+ bilateral pitting edema to the knees. Fortunately, the PCP went down the route of checking the urine because I've had people sent off to cardiology and CAT scans and other reasons that might cause edema, but kidney function was preserved. Albumin was down, wrong way, at 2.9. Cholesterol was very high. And then the urine analysis did show 4+ protein with trace blood and no leukoesterase. So a 24-hour urine showed 11.7 grams of protein, and appropriately, this patient was referred to a nephrologist who scheduled a kidney biopsy. And several days later, the biopsy comes back. The reading is membranous nephropathy with IgG and C3 as fine granular deposits in a capillary loop pattern, which is very typical. And fortunately, as perhaps represented by the normal creatinine, there's minimal scarring, tubular atrophy, or interstitial fibrosis. And these are typical images that you might see as a patient with membranous. So on the PAS stain, you see these very rigid-looking, thick walls. So the membrane of membranous nephropathy is seen here. There's not a lot of hypercellularity otherwise. If you do the Jones methenamine stain that stains the collagen components of the GBM, you can see the spikes and the craters that outline the deposits which are not stained by silver. And then any of the immunoreactants, whether that's IgG, C3, any of the antigens that you stain for, show up, if they're present in the deposits, in this fine capillary loop granular pattern, which more closely, obviously, is seen on the electron microscopy with the effaced simplified podocytes, and then these sub-epithelial, sub-podocyte deposits, several of which have spikes between them. These would be stage 2, Ehrenreich-Scherg stage 2 deposits. Okay, so I think if the audience response is working here, which of the following statements about membranous nephropathy is correct? That it can occur rapidly, the nephrotic syndrome can occur rapidly after the development of a viral infection, that prolonged proteinuria greater than 1 gram a day is a risk factor for progression to end-stage kidney disease, that it's a common cause of nephrotic syndrome in children, or that 30 to 40% of patients can undergo spontaneous remission given enough time. And I think, okay, I'm starting to see 0% answers, so however you do this, please vote. All right, we have at least 2 answers, so I'll give you a few more seconds. Okay, so the correct answer is D, and most people got that. That the rule of thirds says that about a third of patients can go spontaneous remission. Just the other answers, although infections may predisposed to membranous nephropathy. That's still controversial. It doesn't happen rapidly. It takes months to years before something shows up clinically. The proteinuria, interestingly, is a risk factor if it's greater than, say, 5 to 7 grams a day for sustained proteinuria. 1 gram is more what we think about IgA nephropathy. And children don't tend to get membranous nephropathy. It can happen, but it's not a common cause. All right. So as I hinted, the natural history of membranous has an insidious onset, meaning it's slow. It's not an explosive onset of the nephrotic syndrome like minimal change disease or primary FSGS. It happens to, patients notice this weight gain or leg edema that has happened over the course of months. Excuse me. Most patients will be nephrotic at presentation. Some may have subnephrotic, less than 3.5 grams per day. But given time, they often will progress to full nephrotic syndrome. And the classical teaching, and no one has really looked at this in the modern day of autoantibodies, but generally a third of patients will undergo spontaneous remission without immunosuppression. A third will progress towards end-stage kidney disease, especially when they have heavy proteinuria. And the rest of them are just sort of left with proteinuria but stable kidney function. Over whatever time period you're looking, 10 years or something. The resolution, like the onset, is slow and can take months to years before someone can get to a clinical remission. And then unfortunately, relapse occurs in 25 to 30%. We don't really know what triggers a relapse. So I'll talk a lot about the PLA2R system, the phospholipase A2 receptor. Before 2009, we didn't know this was a podocyte protein, but it is found, this red staining here in all the podocytes in this human biopsy. About 70 to 80% of patients with primary membranous nephropathy will be seropositive for autoantibodies against PLA2R. And then in disease, I'll show this in a schematic next, that the antibodies and the antigen itself co-localize in immune complexes that basically we now know are cleaved off. The PLA2R is cleaved and ends up in a deposit beneath the podocyte. There is a genetic association with the gene for PLA2R1 and the class II MHC alleles. And importantly, this is a very specific test, either the antibodies or the PLA2R within the deposits specific for membranous nephropathy. And as we'll talk about, there's a lot of good evidence that anti-PLA2R in the circulation predicts clinical disease activity. So in this schematic, the red squares are PLA2R. It's within the cytoplasm. It's expressed on the basal surface. If you have antibodies, we know that they go through the endothelial fenestrae, cross the basement membrane, and then cause shedding of the deposits. There's actually a protease mechanism, ADAM10, ADAM17, that cleaves the PLA2R so that the ectodomain can end up in these deposits with antibodies with complement. Complement's activated. The membrane attack complex attacks the podocyte. The anaphylatoxin C3A, C5A get released and can also trigger complement receptor-dependent responses within the cell. So the PLA2R doesn't fully go away in the podocyte. There's still this blush of brown staining here, but it certainly is concentrated within the deposits. So this was one of the first staining tests that the pathologists did. They stained membranous nephropathy biopsies for the antigen PLA2R. And if you look at the whole spectrum of membranous nephropathy, that's primary, secondary, about 55 to 60 of all the cases of membranous will stain positive for PLA2R. So these would be PLA2R-associated membranous. And then if you're staining for PLA2R, there's going to be 40%, 45% that don't stain, and you have to figure out what that other antigen is. That can be done with other staining, or several laboratories are now offering a mass spec analysis that tells you which protein is concentrated in those deposits. So I've talked about primary, we used to call it idiopathic disease, or secondary, meaning secondary to lupus. Dr. Appel just talked about that. Infections like hepatitis, malignancy, or medications. But we're tending to get away from that and trying to talk more about target antigen. So we have PLA2R-associated membranous. We have exhaustocin, which is a lupus-associated membranous nephropathy. But there are some histological features that may point you in one direction or another. The secondary diseases tend to have, in addition to the subepithelial deposits, mesangial and subendothelial. They may have tubulo-reticular inclusions in lupus. So histology can still help you out, sort of knowing which antigens to look for. So PLA2R, why was this finding sort of revolutionary? And we're now seeing other diseases trying to model themselves after sort of, can autoantibodies predict disease course, like anti-galactose deficient IgA molecules? Prior to this, we could only follow disease with proteinuria, serum albumin. We know that clinical remissions occur very slowly in membranous nephropathy. But now that we have a serological marker, we can test that in the blood for diagnosis, for monitoring. We know that serology precedes and predicts clinical course. So ultimately, we make better and faster decisions. So this was something just based on very early work in the lab with Western blotting. We knew that the antibodies came down and disappeared. We call that immunological remission before the proteinuria did, before that patient made it to a partial remission or a complete remission. So in terms of diagnosis, for IgA nephropathy, we know we have to do the tissue biopsy. In membranous nephropathy, we can also test the blood for serological testing, and that's called a non-invasive diagnosis of membranous nephropathy. That was popularized by the Mayo Clinic, Shane Bobart's articles, but it was the first practice point in the 2021 KDIGO guidelines, saying that you should measure the antibody. If it's absent, you need to do the biopsy, but if it's present and the patient has normal kidney function, you can make a non-invasive diagnosis of membranous nephropathy as long as you've excluded diabetes, other potential secondary causes. You should remember that even if the patient is seronegative for anti-PLA2R, you could still be dealing with membranous nephropathy that has already gone into an immunological remission. So in that case, you would find deposits, but that patient would probably remain seronegative. And you probably shouldn't treat that patient. So other antigens have been discovered. I'm not going to talk a lot about these. We don't have blood tests for them yet, but NEL1 is a big one, accounting for about 10% of all membranous. Interestingly, it's found with malignancies and certain medications like NSAIDs or alpha-lipoic acid. I mentioned that exhaustosin 1 and 2 are associated with the lupus membranous. THSC7A is a rare cause, but can be found in certain malignancies. Semaphore N3B is found in pediatric. And HTRI1 was another antigen discovered in our laboratory with Laith Al-Rabadi in Utah. We're finding that in the very elderly patients with membranous. So the KDIGO does say, in all cases, no matter what the antigen, you should think about age and population appropriate cancer screening, think about autoimmune diseases, infection. We tend to rule out all these viruses and treponemes for when we have a patient with nephrotic syndrome. And then medications is interesting. This alpha-lipoic acid, which is in a commercial nerve agent that can be bought over the counter, has been implicated in NEL1 membranous nephropathy. So it's important to ask patients with membranous about their medicines. Malignancy has been historically difficult to ever separate. Older patients get membranous nephropathy. They also get tumors. So it may be a coincidental occurrence in some cases, like PLA2R, but in things like NEL1, often that is pointing to an occult malignancy. So if that patient has membranous, has some secondary features on biopsy, doesn't stain for PLA2R, does stain for NEL1, it's worth screening your patient more than perhaps the age-appropriate malignancy screens. So who gets treated with immunosuppression? You've heard a lot about immunosuppressive drugs today. We think about acute problems with nephrotic syndrome, such as venous thromboembolism, weight gain, cosmetic issues, but there are also acute effects of treatment, right, immunosuppression. And then we think about long-term kidney health, but there are also late effects of treatment, for example, bladder cancers with cyclophosphamide. So one of the things that is somewhat unique to membranous nephropathy is that it does have a very high risk of venous thromboembolic disease. When the serum albumin drops below 2.8, your risk greatly increases. So you have to think about patients who are low bleeding risk, should I anticoagulate them? Traditionally it's been with warfarin or heparin products. I think despite having a lot of data, people are starting to use the oral agents, the Pixabans, et cetera, which have limited evidence that they're useful. But there are also case reports that they haven't prevented clots. Irrespective of whether you're going to treat with immunosuppressive therapy, you want to do RAS inhibition, possible SGLT2 inhibitors, there's less data there. Obviously blood pressure control, volume control, sodium restriction, and because of the hyperlipidemia, they often need statins or other lipid-lowering therapies. In terms of immunosuppressive therapy, we should really restrict that to the patients that we think are going to progress either a long duration of membranous nephropathy or that are sort of heading already to loss of EGFR. And KDIGO gives a schematic which is sort of confusing. I've tried to make it simpler here. It's all based on the Toronto GN Registry's analysis that patients who have a sustained proteinuria under 4 grams a day or subnephrotic have low risk of progression. Those in the 4 to 8 grams a day tend to have moderate risk, and those over 8 grams for like a sustained months period are at the highest risk. So KDIGO has added certain other features to this. Low risk is still if you can get your patient less than 3.5 grams a day, or if they've had a greater than 50% decline in proteinuria, that's a low risk patient. If they remain over in the nephrotic range and their proteinuria hasn't decreased by 50%, that could either be a moderate risk, or if they start with a low EGFR or the proteinuria ends up over 8 grams, or if we have a seropositivity for PLA2R, sort of an arbitrary threshold, or their serum albumin is quite low, these are the higher risk patients. And then very high, rapidly declining kidney function, life-threatening nephrotic syndrome. So the second question, 36-year-old woman has PLA2R-associated membranous on biopsy. She smokes, she uses marijuana products. Conservatively, she's put on optimal doses of losartan, torsemide, atorvastatin, with good control of her blood pressure, but her proteinuria only goes sort of less than 50%, from 13.5 grams to 9 grams a day after 6 months of therapy. So she's in this period where we can now place her in a risk category. So if you do choose immunosuppression, what's the most appropriate choice in this patient with the goal of achieving a sustained remission, meaning no relapses of her proteinuria? So cyclosporin, the modified Ponticelli regimen, alternating months of cyclophosphamide and steroids, rituximab, mycophenolate, or eculizumab, the complement inhibitor. So if that's coming up, I don't see the answer screen. Okay, here we go. All right. I think in interest of time, we'll end it here. The correct answer is C, rituximab, anti-B-cell, anti-CD20 therapy. We'll talk about cyclosporin. We'll talk about, or cyclosporin and the calcineurin inhibitors, the modified Ponticelli. Mycophenolate has been tried in membranous. It doesn't work that well. And then eculizumab, there also was a trial that never made it to see the light of day, but probably was not dosed appropriately and did not end up showing a benefit in membranous nephropathy. Okay, so again, low risk, moderate risk, high risk, very high. Those that are low risk, those that have declining titers of anti-PLA2R probably are heading towards remission, and you can watch and wait. Those that make it into the KDIGO high risk or have increasing titers, so we know that disease is going to continue to go on, or they start with a very high anti-PLA2R level, generally need the immunosuppression. And choice is, I think it's really up to a discussion between the patient and the treating physician about what's going to be the least side effects with the most efficacy. So Ponticelli regimen, which used chlorambucil, the modified Ponticelli, which uses cyclophosphamide, uses alternating months of steroids and alkylating agents, 6 months total. It works very well. They're 2 studies with 10 years follow-up. 92% of patients have kidney survival at 10 years versus only 60 that had supportive therapy. The complete and partial remissions come at 1 year, 2 year, 3 years, so you're maxing out at that time point. But my point is that it does happen late. So the duration is 6 months, this little blue arrow down here, and you start to see the complete or partial remissions well after that. So it's not a quick treatment response. You have to watch the serum albumin rise, you have to watch the proteinuria go down over an extended period of time. And this is the other study, it's an Indian study that also had 10 years of follow-up. But we know that alkylating agents have lots of toxicities, bladder toxicities, late malignancies. So in this patient who was a smoker, I probably wouldn't have chosen an alkylating agent as my first choice. But those with high risk who need the quickest way of getting the anti-PLA2R down, this therapy does work. What about cyclosporin was the first CNI to be used. Tacrolimus became more popular as it was used more in transplant. But this is a small study from many years ago, but it really hammers home the point that patients with membranous nephropathy were treated, and this is 2 months, 6 months, 12 months. You see the complete and partial remissions going up. When the tacrolimus is tapered, you still have these same number of percentage of partial and complete compared to the placebo, but this is now 12 months later, you've had basically enough relapses that there's no significant difference between the control group as that patient is off the CNI. So we see the same thing in Mentor, we see the same thing in Majesty that came out recently, and we'll look at that in a bit. So just quickly, there are adverse effects to all of these calcineurin inhibitors. We think about hypertension, loss of kidney function, alkylating agents we've talked about, cytopenias, infertility, in this case, which is a 36-year-old woman, still may want to get pregnant. So we need to consider these later effects. So this was the first randomized trial in membranous nephropathy that looked at rituximab, anti-CD20, versus cyclosporin. And it was designed initially as a non-inferiority trial, and at 12 months, rituximab was non-inferior. There were 60% remission rate in the rituximab group versus 52 in the cyclosporin. But look what happened at 24 months. So you maintained all of those remissions in the rituximab group, but you basically lost them all after the cyclosporin was tapered off. And looking at this graphically, we see that rituximab, 6 months, 12 months, up to 24, you get more partial and complete. You get more total complete remissions, 35% by 24 months. That's less than 0.3 grams, difficult to do in membranous. Whereas cyclosporin, you go up to 52% at 12 months and then drop down and have no complete remissions in the calcineurin inhibitor cyclosporin group. So now we have Majesty. This was designed in the same framework as Mentor. So it was an anti-CD20, obinutuzumab, versus CNI tacrolimus, had more escape clauses where patients could switch treatment arms, and many of them ended up in the anti-CD20 group, but basically showed similar findings. Obinutuzumab was a little quicker, so made it to 36% complete remissions by 76 weeks, maintained that. Unfortunately, didn't get a whole lot better at 2 years, 36 to 37%, but tacrolimus did dismally, as in Mentor, in getting the patients to a complete remission. In terms of relapses after a patient gets to remission, in obinutuzumab, you've wiped out the B cells, you've pretty much wiped out the anti-PLA2R, you don't have a lot of relapses, whereas once you taper off tacrolimus and you have that CNI effect on proteinuria that goes away, you get full relapses of nephrotic syndrome, which makes it worthwhile, I think, whatever immunosuppression you're using, to follow anti-PLA2R. And if at the end of 6 months it's absent, you can probably taper off your therapy. If it's declining, your therapy seems to be working, so continue it. And so recheck at a later time point to see if it's disappeared. If it's still present and really hasn't declined, then I would question what therapy you're using and maybe consider switching. or giving further doses, for example, of rituximab. It may come down at 6 months, and then you need to redose to get it to come down further by 10 to 12 months. Just a point that the anti-PLA2R test is FDA cleared for diagnosis only. So we all use it off-label for monitoring disease, but technically this is a non-FDA approved use. So I think you'd be justified if anyone called you on it, since everyone does it, and international guidelines point to its use. All right, so quickly, membranous nephropathy does come back in the allograft. If someone has circulating anti-PLA2R that's caused their kidneys to fail, they get a preemptive transplant, they go on dialysis, and they still have the antibodies around. Those antibodies will quickly bind to PLA2R in the allograft and may or may not cause clinically relevant disease. If the transplant immunosuppression is in that individual strong enough to get rid of the PLA2R producing, anti-PLA2R producing B cells, they may not get more than just a biopsy finding of deposits. But if they go on to have increasing levels of anti-PLA2R, they will get clinical disease. That's why the incidence of recurrent membranous nephropathy can vary anywhere from 10 to 45%. It can be 45% in those that do protocol biopsies at 4 weeks and will find deposits bound under the podocyte. But if you're looking for clinically evident disease, it's probably closer to the 10%. Those that do develop nephrotic syndrome, it tends to be a year out after transplant. Again, reinforcing this point that it takes time for these deposits to build to a state where the podocyte and this filtration barrier falls apart and leaking nephrotic range proteinuria. So we do see anti-PLA2R with recurrent disease, but not de novo disease, which interestingly has been associated with other autoantibodies, or at least an antigen in the de novo MN deposits. It's an antigen called FAT1. But whether or not that patient is seropositive probably should not affect your decision to transplant them, because you can treat it afterwards. The transplant immunosuppression is often enough to get rid of it, and you can give rituximab during transplantation, after transplantation. But definitely heightened surveillance is indicated in that case. So quickly, some take-home messages. Membranous nephropathy is not one disease. It's a group of related disorders that's marked by these subepithelial deposits that have distinct antigens, PLA2R, THSA7A, NEL1, et cetera. The major form is PLA2R associated, but I think there are up to 30 different antigens at this point. The other ones you should know about are the exhaustocin, X1 and X2, which are lupus membranous nephropathy associated. NEL1, remember these are medications like alpha lipoic acid, NSAIDs, skin lightening creams, traditional medicines from India. And then THSA7A has been associated with tumors that express THSA7A. So non-invasive diagnosis in a patient with all the features of nephrotic syndrome, preserved kidney function, no diabetes, no associated other secondary causes, seropositivity for anti-PLA2R is enough to diagnose that patient with PLA2R-associated membranous. And although KDIGO says you shouldn't go on and treat without a biopsy, I think many of us are treating the patients and following the anti-PLA2R. We know that following serology can be useful for treatment decisions, starting, stopping, changing. In proteinuric patients, if you get that patient that's nephrotic, but their anti-PLA2R is 100, the first time you see them in clinic, and then it's down to 20 the next time, I would just continue to watch that patient because they're going into an immunological remission. Those high-risk patients, those that start with lower EGFRs and have persistently positive anti-PLA2R, are those that are at risk of progressing and should be treated. Rituximab has certainly become first line. We'll see what happens with obinutuzumab after the publication of the Majesty trial and whether FDA approves that for the use of membranous nephropathy. The modified Ponticelli with alternating steroids and alkylating agents certainly works, but save it for the appropriate high-risk patient that you're not going to do damage to their gonads or bladder or bone marrow. It works in patients who are otherwise going to have a very bad course with membranous nephropathy. And treatment should be continued until all the serologically evident anti-PLA2R is undetectable. So I think the rest of it, I just have some clinical trials. I will one day put Majesty in here when I have more room in the table, and just some other thoughts on immunosuppression and references. So I think that's it. So thank you for your attention, and looks like time's up.
Thank you, Larry. That was excellent. We'll save the questions for after the next session.